Good evening, everybody, and good evening to the officers and those committee members that are dialing in remotely to the Health and Adult Social Care Overview and Scrutiny Committee, 17th of January 2022. Joe, would you like to read out the housekeeping notices, please?
Thank you, Chair. Please note that this meeting is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. Please could everyone present follow these ground rules. Only speak when invited to by the Chair. For those present in the meeting room, please use the microphones on your desk when speaking. If accessing the meeting via Microsoft Teams, please turn on your video function before speaking. Again, if you are accessing via Teams and would like to speak on an item, please do so by using the Raise Your Hand feature in the bar at the top of the window. For those in the room, if the fire alarm sounds, you must exit the building by way of the nearest available signed fire exit route and make your way to the ground floor of the multi-storey car park. Finally, please ensure background noise is kept to a minimum and that mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you, Chair.
Thank you, Joe. I'd like to welcome our portfolio holders who are joining us remotely, Councillor Rampton and Councillor Iyengar. And the officers that we have are Phil Hornsby, Director of Commissioning for People, David Vitti, Director of Adult Social Services, Betty Butlin, Director of Operations for Adult Social Care, Elizabeth Saunders, the Interim Director for Adult Social Care Commissioning, Tim Bryson, Head of Access and Carers Service, Nicola Hiles, Emergency Duty Service Manager, Sam Crowe, Director of Public Health Dorset. If I've missed anybody, would you mind raising your hand and introducing yourself? I'd also like to welcome Louise Bate from Health Watch there. Evening, Louise. I'll now move on to the agenda items. Apologies. Have we any apologies for this meeting?
Thank you, Chair. There are none, and subsequently there are no substitutions. Thank you.
Thank you. Agenda item 3. Are there any declarations of interest? Councillor Evans.
Thank you, Chair. Just for transparency, I work as a bank employee of University Hospitals Dorset.
Thank you. Councillor Matthews.
Thank you, Chair. Again, just for transparency purposes, I'm a governor of University Dorset Hospital Trust.
Thank you. Councillor Johnson.
Thank you, and I'm an employee of Royal Bournemouth Hospital. Thank you.
Thank you. Move on to agenda item 4, confirmation of the minutes. Anybody, any points to raise from the minutes? I know I have a couple of ones, but anybody else got anything to say on the minutes? No. If you wouldn't mind, I just want to ask a couple of things that could possibly range as action points for a further meeting. On page 7, on what we plan to do, I just wondered if the PAN vision for Dorset is likely to be ready with BCP and whether we have an outcome that we could have as an update for another committee. It says the 2 workshops have taken place and the outcome of this work will feature in the next stage of the vision and would be completed by mid next year, which is this year. So I wondered if we could just put that on our action plan to see if anything was happening with that. Okay, thank you, Joe. And on page 8, on the waiting time for diagnosis, I just wondered, at the time of our minutes, it was 16 weeks and we were looking for a target of 6 weeks. And I just wondered if we had any update on that as to whether they brought it down from 16 weeks at all, because there was extra staffing going on with that. And on page 9, Home First, the hospital discharge, but I think that will come on to our agenda item 8, so I will sort of leave it there. And page 11 on the readmission figures. The committee heard that the readmission figures within 24 hours of discharge were being sought by the service in order to circulate for members' consideration. That has been done as an action, still working on this. But other than that, I think the minutes, I think we can okay those. So thank you, Jo, for taking those. Yes, Councillor Rampton.
I'm not sure that you can see my hand, but I'm not sure that portfolio holders are recorded as being present at committee, but I just wanted to say that I did give my apologies for the last meeting, but they're not recorded. Thank you.
Okay, noted, Councillor Rampton. Agenda item 5, public issues. Have we any public issues for this meeting?
There are none for this meeting, Chair. Thank you.
Okay, thank you, Jo. And agenda item 6, action sheet. I noticed that earlier today on action 174 that the front door service satisfaction survey, we were sent a response to that. Has everybody received it? Yeah. It was sent earlier today. You might not have had a chance to see it. So that one, I think we've actioned, and we were also sent the carers strategy survey, action 170. Has anybody got any questions on that? Councillor Butler.
Yes, we were all given a chance to feed back, which was good. And the thing I would note is some of the questions are really useful, especially assessing the information sources preferred and the highlight of training needs for carers. And also the results of the survey are important for everyone to see on question 20, because actually people are asked if they want to see the results, but I think everybody should, because then everybody has an idea of others' points of view, which I think could be quite useful for carers and for all of us as well. And hopefully we will get the responses to that back, but I'm not sure what date we're going to get that.
Phil, is that your territory or is it Betty? I don't know whether you could come in with an answer there for Councillor Butler.
Sorry, Chair. I'd have to go back and find out what the timeline is around that. I don't have that information to hand tonight, but I can certainly update committee post the meeting.
Thank you. Anybody else got any questions on that survey or action on that one? No. Okay. Can we move on to agenda item 7, the COVID-19 update? Sam Crow, would you like to bring us up to date on what's happening, please? Thank you.
Thank you very much, Chairman, and good evening, committee members. If you just bear with me, I'm just going to share my screen. I've got a very short presentation which will just bring us up to speed with the current situation. So I'm hoping that you can now see that on your screens.
Yes, we can. Thank you.
Okay, that's brilliant. So the last time that I came and provided an update back in November, we were starting to see an increasing rate of cases. In fact, cases have been very much higher throughout the autumn period, which is a point that we made to the committee last time. What you're seeing on the chart at the moment is the epidemic curve including the autumn period. And you can see since that time, we've obviously had a very sharp increase in cases due to the new Omicron variant. So almost all cases now are of the Omicron variant, and that really started to take off in the second week of December, which you can see very clearly in the chart here. The different colours represent BCP Council and some of our neighbouring councils, and you can see that just around the New Year period, in fact the first week after the Christmas holiday period, BCP Council had a very high rate of cases, almost touching 1,500 cases per 100,000, which is higher than at any time since we began testing for the virus. Since then, we've seen quite a fall. So based on the information I looked at this morning, cases fell over the weekend to around 811 cases per 100,000 for BCP Council. Dorset Council also down at 690 cases per 100,000. And that pattern is continuing through other councils across southwest England. So the average for southwest now, 812 cases per 100,000. And England is also starting to come down from those very high rates that we've seen over the past 2 or 3 weeks. Good news also on hospital admissions. So the number of people in our local system down slightly on the previous week. There are now 77 people in our local hospitals with COVID-19. Just moving on to some of the key policy changes that have happened over the past week or two. From today, there's a change in the isolation period, and people can end their self-isolation after day 5 if they've tested positive, as long as they've had 2 negative lateral flow tests 24 hours apart. We've put together a graphic on the right-hand side because this is not straightforward sometimes to explain in words, but the ladder hopefully makes it fairly clear that if you count day 0 as the day that your symptoms start, or if you are asymptomatic, that's the first day that you test positive on a lateral flow test, and then you isolate for 5 days. But from today, you can start lateral flow testing on day 5 of that isolation period. And if you time your tests correctly, you should be able to end your self-isolation on day 6, as long as those 2 lateral flow tests have proved negative. If you continue to test positive, then the graphic also highlights that you can end your self-isolation period if you don't have a temperature, so there's no need for a further test. One of the other changes that's happened over the past 2 weeks is that if you're testing positive on lateral flow test, you now no longer need a confirmatory PCR test. But if you are intending to claim any of the support payments, you'll still need to get a PCR test to trigger the evidence for those payments to be made. And of course, you should still get a PCR test if you're symptomatic and isolate immediately if that proves to be positive. Just a few notes about the vaccination programme. It was very successfully locally and ramped up very, very quickly over the last few weeks in December. At one point, the Dorset system was administering around 15,000 jabs per day, so far, far higher than at earlier points in the pandemic. It has since fallen off. So after the holiday period, they are now seeing around about 1,500 people per day. But I'd make the point that we've covered around about 83% of the eligible population. So that is the population that have had their dose 1 and dose 2. So a huge achievement to get that level of coverage in the population. People connected with the vaccination delivery are now using the time to think carefully about how we deliver the vaccination in a more sustainable way and make sure that the workforce is being used in the most effective and efficient way possible. So some employees that were deployed on the vaccination programme will be going back to their previous roles just to cover some of those shortages that are currently occurring because of absences because of COVID-19. The focus is very much on trying to provide second doses for 12 to 15-year-olds, and we're also awaiting guidance on the delivery of the vaccine to clinically vulnerable 5 and 11-year-olds. I'll just make the point that we're also waiting for a decision from JCVI on whether to roll out the vaccination further to 5 to 11-year-olds. The trusted voices and vaccine ambassadors are still very active, working with communities to try to improve the way that information is given about the vaccinations and improve take-up for some of the groups that perhaps haven't come forward as much as we would like. And there's work now going on in the system to look at some of the inequalities around vaccination, particularly around dose 1 and dose 2. We've still got a large number of people in the population who haven't had dose 1 or dose 2. There's a big focus now on understanding how to get the vaccine to younger people in that. So the 18 to 39-year-old age group is very much a focus of the work at the moment, and understanding how best to reduce the gaps in coverage. And my final slide, really just summarising some of the key issues and actions currently. Committee may be aware that the current restrictions that were introduced, first of all, in response to Plan B, and secondly, in response to the Omicron variant, will be reviewed on January the 26th, and we'll update our communications locally via the meetings that we'll hold with the local outbreak engagement board that week. I've talked about the isolation rules changing. It's important that we realise and understand that those rules have been changed to increase systems' ability to bring people back to workplaces safely. So one of the things about this current wave is it's had less impact in terms of hospital admissions, but it's perhaps had more impact because of high transmission in the community on people in frontline roles. So those changes are partly as a result of efforts in the system to try to ensure that people can return safely to the workplace as quickly as possible. It is very busy still, so our Public Health Day response team is probably had its busiest day post-Christmas. We're supporting lots and lots of schools and lots of care settings at the moment who are managing an increasing number of incidents and outbreaks. Testing, the supply of lateral flow tests has definitely improved over the last couple of weeks, and there is PCR capacity locally, so no concerns on that front at the moment. And we're continuing to provide targeted assisted lateral flow testing in some of the high visibility locations. In terms of the modelling that our Epicel has been doing, it does seem as if we're now following the best case scenario. So they predicted 3 scenarios in terms of cases and hospital admissions. And so far, it looks as if we're following the best case scenario, which is really, really positive news. And we hope that that trend will continue and that we'll continue to see a fall in cases and hospital admissions. But I'd just make the point that at the moment, when we're looking at the case data, it's difficult to tell how much of that fall in cases is due to genuine lower prevalence, whether it's linked with fewer people coming forward for testing. And partly that may be because there's more asymptomatic infection or subclinical infection that may not be being reported, partly because people are not aware that some of the symptoms that they're having, if they're very mild, actually could be COVID. So quite difficult to unpick all of that, but we're tracking the national prevalence surveys that are being carried out by the Office for National Statistics. You can already see quite a marked fall in the prevalence in London. Southwest is at much lower prevalence, and hopefully we will continue to see a sustained fall, not only in our case data, but supported by that prevalence data. So that's all I wanted to update committee on tonight. I'm happy to take questions.
Thank you, Sam. I believe Councillor Iyengar had his hand up. Is that for to add or to ask a question?
Oh, excuse me, Chair. I'm sorry, I wasn't aware that my hand was up. Excuse me, I don't think my hand is up on my screen. I apologise.
That's all right. Any questions? Councillor Robson.
Yes, I'm just interesting that the 18 to 39-year-old group, certainly from the people I talked to, they do seem to have given up slightly on the process. I was just wondering if there's been any, first gut reactions to why they're not taking up or where they're not responding. It's interesting what you said right at the end, and that's what I've been hearing as well, is that it's possibly that age group that aren't adding to the figures because they're sort of moving on and not bothering with it. And the sort of part 2 to that, I was wondering if those individuals in our community that aren't necessarily registered with a GP, do we have a handle on how many of those might be in the community and not being processed or jabbed as well? Thanks.
Yeah, thank you. So I'll take the first part of that question. I think it's probably a combination of factors. What we know from some of the research and also the previous experience is that sometimes younger people won't go out of their way to travel to a vaccination site. But if you can make the offer very, very clear, if you can make it very, very convenient, that's how you can get lots of people vaccinated quite quickly. So some of the earlier efforts where we were turning up and offering vaccinations at university sites and other sites is something to bear in mind, thinking through how we differentiate the offer. I think there's also definitely a perception that this current strain of the virus is much less severe, which is great news. But the side effect of that is that people may now be thinking, actually, we're going to have to live with it. In my age group, if generally the symptoms appear to be fairly mild and I'm not seeing any of my friends particularly affected or going into hospital, then that weakens the incentive to come forward for vaccination. So there's probably quite a few different reasons. And one of the pieces of work that's going on is perhaps less command and control pushing out of information about the vaccine offer and more genuine engagement. So asking why people haven't come forward. I think also I'd make the point that it's not necessarily people from difficult or hard to engage with or hard to reach communities. There are some fairly large numbers of people in the younger age groups in sort of fairly affluent places in Dorset that have not come forward, which suggests that it could be just due to young people getting on with their lives, perhaps not seeing that it's important to come forward for vaccination now. So a piece of careful work is needed to think through how we understand what some of those barriers may be and how we can start to work on a differentiated offer, because it's still important to get boosted. And we may well have had a bit of a near miss with this virus in terms of its severity. So lots of work to do. And I think we're seeing a shift now from that very, very rapid standing up of the vaccination effort to something that needs to be much more planned, much more considered groups that may not be registered with GP surgeries. So some of the homeless, for example, and we've been working through the system to deliver those offers to some of those groups. But I don't have an idea of numbers exactly, but I'm happy to provide some information post committee if that would be helpful.
Great, thanks, Sam. Cheers. Thanks, Chair.
Thank you, Sam. Councillor Rocker, I believe you have a question for Sam Crowe.
Thank you, Chair. Yes, it regards the changes in with the PCR test, lateral flow test. So we know that these changes will affect the number of the cases because people maybe are not going to register if they're positive, because that is, having a lateral flow test, you need to go or using the app or going on the government website to register your result. Also, you can register that is negative, maybe it is positive, because there is no picture of the test to upload. So do you know how much it could affect the difference between the real cases that will be in the society and actually those that will be registered? Thank you.
Yeah, thank you. To some extent, it's uncertain locally because, of course, we never, we can't count tests that aren't reported. But you can get a reasonable idea by estimating what our local prevalence would be from the national prevalence surveys. The sample size is large enough at a regional level that it gives you a fairly clear idea. So if you look at the week that we've just had, so the first week in January, the prevalence in London was around about 9%. The prevalence in the southwest was 3.4%. So you can project that on using our local population data and get a reasonable approximation for how far off we are. My sense is that this week, some of that fall that we're seeing in the actual case numbers is because people are not coming forward as much for testing. We think testing's down probably about 25% at the moment. But of course, there's lots of different factors playing into that. So I think the best method is to look at the national seroprevalence surveys and then see how big the gap is. A lot of the national epidemiology reports have now switched to using the seroprevalence surveys rather than testing data. And I think that reflects the change that we're in at the moment, which is learning to live with COVID. And testing is still really important because it will tell you your own COVID status and obviously give you that instruction then to isolate and not spread it further. But we may be certainly in periods where prevalence is higher, And the public health advice is not to seek a confirmatory PCR test. We're always going to run the risk of not counting every single positive case, as many people will just test positive on lateral flow and then not record it.
Thank you. You happy with that, Councillor Rocker?
Yes,
Sam,
thanks.
yep. Sam, can I just ask you, are there any plans in place for booster number 2? So that would be jab number 4 for the extremely vulnerable?
I can't remember off the top of my head. I can provide an update to committee. I'll check in with the vaccine cell because I can't remember exactly the national position on that.
Okay, thank you. Any questions from anybody else? No? Councillor Evans.
Thank you, Chair. Just a very quick question, Sam. If we're not doing confirmatory PCR testing, how are we going to know if variants change again?
Yeah, it's a really good question. I think probably what the epidemiologists would say is that we always see a number of variants, but very few take off to the extent that Delta took over from Alpha and now Omicron has taken over from Delta. So you're absolutely right that when we don't test using PCR as much, you can't genotype the exact strain of the virus. So I think what the epidemiologists do is to try to look for signals that indicate there's a change in the way that the virus is spreading. So if you suddenly start to see an increase in cases and you see that in several regions, then that's a signal to start to go and look for it. And of course, there's still a lot of PCR testing that is being done in the background, and a fair proportion of those samples are being genotyped. So there's underlying surveillance, but we're definitely not doing as much PCR testing as we have been in the past. And one of the things that we'll have to think about is having an effective strategy to make sure that we're maintaining effective surveillance for variants, and whether we're confident that we could see early enough signals. If we get a new variant that looks as if it's going to become dominant, how quickly can we pick that up? But it's a really good question.
Okay. I believe Councillor Rampton gave an answer, well, she typed one in to my question on jab number 4. Councillor Rampton, did you want to say anything about that?
Just that really, Chair, thank you. That I know my next door neighbour who has a heart condition has just had his, and I'm aware of a couple of other people I know who've got jabs booked in. So that I think there is starting to be a rollout on the most vulnerable.
Thank you for that. Anybody else? No. Thank you very much, Sam. Thank you for the update.
No problem. Thank you very much.
Right, shall we move on to agenda item 8, which is the impact of the pandemic, COVID-19, on adult social care. Can I just say we've got 2 recommendations here. One, that the committee reviews the report, and secondly, the committee makes such recommendations as it sees fit to Cabinet for consideration. So if you can bear those in mind. Thank you. So Betty, are you going to take the lead on this for us?
Yes, I am, Chair. Thank you. So I put together with some colleagues who are also going to answer any questions. I put together some slides, so I'm just going to run through the slides as it is quite a lengthy paper. So next slide, please, David. Okay, so just providing some background, as we all know, we're facing a unique set of winter pressures. We've had the pandemic and are still in the pandemic, and we've had the national mandated measures which were put in place in March 2020. We've seen pressures on our emergency departments and our acute hospitals, all of them facing heightened demand due to the pandemic, coupled with an emerging winter, which brings with it its challenges such as flu, and as Sam just went through, some of the infection rates. We've been in incident management, hospital discharge schemes, and how we're managing to support our population through that. What I would say is that One of the really positive things that's come from this is the collaborative working and the real sense of working together and joined working across our whole system. We've seen workforce challenges. We've seen some workforce shortages. In adult, just to give you an example, in adult social care operational areas, just at the point of compiling the report, we were carrying around 25 vacancies, although more than half of them had candidates marked against them. And those vacancies were around social work and occupational therapy, just to give you a bit of a tangible kind of insight into there. We have been struggling nationally to recruit certain areas of staff, therapy in particular, OT, and the challenge has been to get those really experienced, skilled practitioners at the speed and pace that we would like to recruit them. Next slide, please, David. So just some of the system pressures that you'll be aware of, broken them down into just 3 key areas for this. So you've got our acute hospitals, and we continue to see challenges with our occupancy rates. Our occupancy within our acute hospitals has been sitting around 95+%, which in essence means that we have very little scope for further bed capacity at that level. Our community hospitals have been under pressure as well, and our mental health hospital environments. And primary care, as you know, GPs have been, our primary care colleagues have been very heavily involved in the vaccination programme and the boosters, and then that just puts added pressure onto primary care. Next slide, David, please. So just looking at some of the information around the care market. So since August 21, 76 packages of care were handed back to BCP Council from a range of 21 providers. There are currently 150 registered care providers in BCP area. And at the time of writing this report, which was only a few weeks ago to get it submitted, that was the number of suspensions, but I can tell you today suspension numbers are 87%, which is around 59%. So it is going down, and we are starting to see those suspensions reducing, albeit slowly. So that's positive, and we're pleased about that. Feedback from providers is that staff morale has been low, and you would expect that because staff have been really tired. There are staff shortages, as I've said, because of the COVID infection rates and the staff having to isolate, and also some people choosing to maybe go into different areas of practice. And just some residential care staff around the double vaccination, 75 or 95%. And at the time of writing this on the 6th of January, there was 31% that had had the booster. Thanks, David. Next slide. So operational pressures have been around. We have seen a 40% increase in our hospital social work demand. So these are our one teams who support the hospital. We know that from the 1st of April, and all this information is contained within the report, from the 1st of April 21 to December 21, our social work and our one team staff just aligned to the discharge, supported over 3,500 individuals to enable them to return home or to have the care and support that they needed at the time of discharge. Because of the heightened demand, what we're seeing is people are waiting a little bit longer to what we would like them to be waiting, and that number has gone up. And there's some stats for you cited. I think it's page 21 of the report around that. And then we have our resources being diverted to hospital discharge where necessary. So that can put an increased pressure on our community services. We have seen an increase in safeguarding concerns come through, but not all of them result in an actual Section 42, which is the the part of the Care Act where we have to undertake a safeguarding inquiry. Workforce recruitment and COVID absence, I've kind of touched on that. The workforce absence is staff self-isolating or working from home. Next slide, please, David. So we have seen some financial implications, and again, a lot more of this is contained within the report. We've seen increased fees for care homes, and we've also seen patients requiring, or clients requiring, 30% more care following discharge. Now, that's not totally unexpected because people are leaving hospital at the earliest opportunity so that we can free up some capacity for those really needing to go into a hospital bed. So you would expect at that point for people to have an enhanced need to that if they were able to stay and have some further therapy whilst in a hospital setting. The hospital discharge funding programme will end on the 31st of March. That's the funding that's come down to support hospital discharge, and that applies to people that have a new or enhanced need at the point of discharge, and that funding can be for a period of 4 weeks. And within the report, we've put out some details just around some things around the workforce and infection prevention grants that have been awarded to the care sector. Next slide, please, David. And then just to heighten some of the risks and just to summarise that really. So it's the real demand on the care capacity in delivering the care and support, particularly at the speed and pace that we're needing it at the minute. Pressure to discharge patients, then diverting some capacity away from those at home. So what we're really focused on at the minute is having a real balance of being able to support people at the very, very earliest opportunity, but also keeping a really close eye on those that are in need within our community. We have the financial pressure that we've kind of touched on, and some more of that within the content of the report, and a greater emergency use of care homes for people being discharged who may otherwise go home. So what we're facing is if there is a delay, be it short or slightly longer, in order to keep people safe and to be able to discharge them at the earliest opportunity, we work with individuals for them to maybe go into an interim provision, and that might be that they go somewhere other than home as a stopgap for a short period of time in order to be able to then discharge them back to their permanent home or wherever their permanent residency might be. So that's the end of the presentation, this slide. So thank you, David. So the report is in your pack. I think it's on page 17. If I'm right, I think it starts on, yes, it does, page 17. So Elizabeth and I, who's my colleague from Commissioning, our interim director of Commissioning within adult care, very happy to take any questions from committee. Thank you, Chair.
Thank you, Betty. Any questions? Councillor Wilson.
Cheers, thank you. Thank you for your presentation, really good. I just had kind of a question about the care staff, the low morale, kind of because I have read the report and I didn't see anything that's being done to kind of counteract that. And I think that from reading the report, it says about people being exhausted, wanting to leave the sector completely. And I just think that we're probably in danger of, running people into the ground. And it's only going to increase the pressures that we face. So I just wanted to know a little bit about kind of what's being done to try and solve that problem.
Thank you. Elizabeth, are you going to take that question?
Yes, I mean, I have to say I'm quite new to this part of the world, and I've been just so impressed by both our staff and our providers working so hard under extraordinary circumstances. And although staff are really tired, and some of them have got COVID, and we've got all kinds of workforce issues, the fact that we've had 2 large amounts of workforce recruitment and retention funds that have been cited in the report is really positive, because that money is going to be transported directly to our providers who can use it directly with their staff. We're aiming to get up to £150 per person. The money's coming in 2 different trenches, so we've just administered the first trench. We have to work exactly to the guidance and the rules, and it does mean that our providers can decide to give golden handshakes or give bonuses to staff who've been working with us throughout all this. So it's a really positive message, that it's straight over to them to help with the care staff who've been at the receiving end of this. There's all kinds of other things we've been doing to support our providers. We're in regular communication with them. We're offering all kinds of incentives. We gave extra money at Christmas. We've got offers of support for childcare and proud to care examples of parking, and all kinds of incentives that we're looking at frequently to try our best to do our bit to keep morale up and to help staff realise that they are recognised, and we really do support them. So I hope that's helpful, Chair.
Thank you. Councillor Wilson, if you want to add anything.
Yeah, I mean, I think that is quite helpful. But is there any further suggestions that you think that could be done, in not necessarily in terms of financial financial compensation for people or things like that, but and I mean, how long can this low morale keep going on for? Because I feel like it's been quite an extended period. Obviously, it's been a very difficult period for everyone. Yeah, I mean, because for example, the funds that you just mentioned, £150 per person, is that considered a lot, or is
Yeah.
I mean, just to kind of understand that.
Can I respond, Chair? Is that allowed?
Yes, carry on.
Thank you. All the evidence is telling us that the most important thing in this situation is support for managers. So we are in turn giving quite a lot of support to our providers. We meet with our providers frequently. We give them all kinds of support. They in turn are supporting their staff as managers and providers. And I think £150 as a golden handshake or as a thank you for what you've done in the past year is considerable if you're earning £10 an hour. So it really is quite a significant amount to be transported directly to care workers. So I think sometimes it's the softer things that we can do. We can bring together all kinds of incentives, but we can also give our communication, our attention, and our kind of emotional support to let all providers and all carers know that we're in it together, and that seems to go a long way.
Thank you. Can I just ask, on page 20, point number 18, you had a social media recruitment campaign. Do you know how that's been? Have you managed to fill vacancies with that? Has that been successful? Do you know? And can you just, I don't know whether you know, but why do people prefer to work for agencies? Is that because the hours, they can choose the hours, that it's more flexible?
Yes, sometimes the hours are more flexible, and people, especially in the domiciliary, the home care market, do tend to, we try our best to get our providers to not share staff, because it's or pinch staff from other providers, because it's frankly not fair when we're all trying to provide the service from a small pond. In terms of our campaigns to get media campaigns in to get further supported, they have worked in the past. They've dried up a bit recently, but then we're right at the peak of the pandemic, and we've seen something like up to a 60% reduction in care that we've been able to provide from our commission services. So we will repeat the exercise, and we do get really good feedback from when we do. So I hope that's helpful.
Thank you, yes. Councillor Robson.
Yeah, thanks, Chair. Yeah, I had very similar questions to both those really, and I got them marked off on your paper that I was trying to get my head around. And it sounds like care homes are closing because they haven't got the occupancy rates, and yet we've got people waiting to come out of hospital and get into homes. I had 3 campaigns to recruit people, yet it seems we're not recruiting people, but we're getting people on agency staff. I'm assuming that's because they're paid a higher rate, which comes back to the morale question that was asked earlier on. Why aren't we retaining people, earlier? Those sort of 3 things were getting a little confused in my head. Seems there are people out there to do the work, but they're coming from agency staff rather than sort of direct employees into these care providers. I was just wondering, is that correct, or am I getting confused on something?
We do use agents. People have to resort to agency staff in a crisis. If you've got a 60% or 40% reduction in the care you're providing, you do have to sometimes use agency staff. However, I think probably it'd be more wise, Chair, if I was to bring a further note on the percentage of agency staff, because it's easy to get the figures wrong and think it's inflated in our minds. Our providers work really hard on retaining the carers that they've got, the workforce grants, and there's another 2 lots of money coming on stream will really help us to make sure that people aren't reliant on agency staff. And I think we need to deal with the reality of this. Most care homes keep their local staff if they can. I think the domiciliary care market is slightly more challenging, but we do have this agreement that one domiciliary care agency shouldn't be pinching staff from another dom care agency, and they do try and work together. We've got provider groups where we have these discussions to make sure that people are playing by the rules, to make sure they're not pinching each other's staff. So I think the wise thing to do is look at the real evidence of how often we are reliant on agency staff, and I would imagine it'd be less than we think is the feedback I get.
Thank you. Councillor Butler, did you have a question?
Yes. We seem to have quite a big pressure on A&E, and I'm wondering whether GP surgeries could respond to some calls more than they're doing at the moment to check people's signs and symptoms. It seems to be that patients are being encouraged just to go straight in an ambulance to the hospital, which is putting an awful pressure on the hospitals. And also to encourage more education of the public as to things like first aid and home remedies that could be done at home, because I think a lot of people just don't know what to do in certain circumstances. Yeah, I don't know whether that's been looked into.
Yeah. Chair, shall I take one?
Thank you, Betty.
Yeah, and I might bring Sally in. I think I saw Sally. Yeah, I might bring Sally in as well. So with regard to people going to primary care and people going to emergency departments, I think I know our primary care colleagues are doing absolutely everything that they're able to do, and that they are seeing patients, and that they are, doing e-consults and everything that in the most robust way to get patients to provide them with information around their conditions. I think our ED departments have been extremely busy, but a lot of that has been with people that are very poorly too, and a lot of it isn't. It's not all inappropriate people turning up at ED. What we have seen is that people that are turning up at ED departments, emergency departments, are people that need to be seen, and need that kind of care and support from an acute hospital. So I think it's getting that balance. And we know that, primary care have been extremely busy as well. We do know that our demand is up, and some of that could be that people are now feeling able to seek treatment and care, where maybe at the beginning of the pandemic or just shortly into it, they were more hesitant to do that. But Chair, you might want to ask Sally to come in and just add more around primary care. Thank you.
Thank you. Yes, Sally, are you there?
Yes, I'm here, Chair. Good evening, everybody. I mean, Betty explained that very well, so thanks, Betty. I mean, I think what general practice would say is that just like the hospitals, they are extremely busy. It's quite easy to have quite a focus on the emergency departments because that's where the focal point is, but actually every part of the system, whether that be social care, primary care, community services, all the hospitals have been under extreme pressure in terms of demand, not just demand related to COVID, just general demands of people's health needs. So general practice has responded extremely well under the circumstances. I think it's quite easy, isn't it, to focus on the things that are difficult and challenging. But when you think about the contribution that our GPs through the primary care networks have made to the vaccination programme and how they've also managed to keep their doors open throughout the pandemic, which is over a very extended period, we are really extremely lucky across our area for the quality of general practice that we've got. I think we're the only area that have got all outstanding and good practices CQC rated across the country. And we also feature very highly in the GP survey, and we did last year despite the pandemic. Notwithstanding that, though, we do know that we've got variation, and where we've got variation, what we're trying to do is continue to work with those practices to look at how we can share best practice about how they've addressed some of the challenges that they face about managing demand, peaks of demand, their skill mix of their workforce, recruitment, how they can work collectively with other partners and also with other GP practices within their patch to try and ensure that they are resilient and they provide good access to their local population, because we do know that we've got unwarranted variation in some parts of our patch despite the overall good quality. So we're not complacent about that, and we're doing a lot of work with the practices to look at how we can be on a continued improvement journey around access. But I think we do need to acknowledge that primary care, just as much as the emergency departments, are under extreme pressure, and we really are in very, very extreme situations, aren't we, with the current situation? Thank you.
Thank you. Councillor Butler, are you happy with that?
It was just a personal experience I had recently with a neighbour of mine who I felt they'd called the ambulance, but then we spoke to the GP surgery, and I would think that it would have been helpful for her to have had reassurance from the GP that what she was experiencing was maybe connected to her condition, her health condition. So I think a lot of people now are worried that with COVID symptoms, they might have symptoms that they don't know what it's connected to, and they might be frightened that what they've got is connected to COVID rather than something else. And I just feel that if somebody knows their patient, it could cut a lot of time out of the system rather than the ambulance staff having to try from not knowing the person, taking them right through the process to the hospital and everything else. That must make time a lot more used for every patient that's seen. That was just an observation of something that really happened. So I don't know if anyone ever gets feedback for that, but that was just one occasion. Thank you.
Sorry, Councillor Butler, did you want an answer to that, or was it just an observation?
Don't know if there is an answer.
I'm happy to make a response if that's helpful.
Yes, please.
I mean, Councillor Butler, I completely agree with you. And one of the things that we've been trying to do, but it is quite difficult when we know we've got higher levels of staff sickness because of COVID. what we've really been trying to do is to reconfigure how general practice works as a multidisciplinary team to enable the GPs and the highly skilled staff to really provide the continuity to those people that are most frail and those people with longer term conditions that benefit the most from continuity. So I absolutely agree with what you're saying, that the ultimate aim would be those people that are particularly vulnerable, got long-term conditions, they have the continuity from somebody that knows them well and a team that knows them well. And that for the other parts of our population, like myself, adult or working age, I'm more interested in getting access quickly in a convenient time that doesn't interfere with my work. And I'm not so worried about continuity depending on the situation. So all I can say is I completely concur with what you say. That's our ultimate aim. But in periods of extreme pressure like we've got at the moment, we can't always provide that ultimate, that ultimate in terms of that continuity.
Thank you.
Thank you, Councillor Farr. I believe you have a question.
Yeah, thank you, Chair. From listening to the presentation and reading the papers, it's good to see the good news about the funding for staff and recruitment to date. Is there a way to speed up recruiting of professionally skilled practitioners, particularly occupational therapists and social workers, as mentioned? Thank you.
Chair, shall I take that?
Yes, that's fine. Thank you, Beth.
Yeah, so what we're doing is we're stretching, widening our net to where we're going for professionally skilled, because it's not always just professionally trained. I was explaining to someone earlier today that it's about getting that real level of skill. So we want, for instance, if you take occupational therapists, we want newly qualified occupational therapists because we want to grow. And we want to bring in all different levels of skill and experience, but we also want those at the real high and optimum level of that skill, of their skill base. So it's about how we attract and keep those really high level skilled. What I would say is our turnover is very low. What we're seeing is we're seeing people that are retiring. We have an aging population, unfortunately, in a lot of our professionally trained and skilled staff. So we are putting out adverts repeatedly. So we're not just doing them whenever we actually have X number of vacancies. We are working with our universities to attract and to do work with third year students about them coming on board. We're taking more and more students as well, and we're making sure that we interview really quickly, and we're cutting down that length of time that it takes from advert to candidates being offered and then able to come into post. The difficulty that we face is that most, if not all, experienced professional staff, unless they're coming back into the workforce, haven't had a period away, they will be working in organisations where they have usually a 3-month notice period that they have to give in order to be able to take that post. So I wouldn't want to give the impression that we have a high turnover. It's not that. It's just that we're saying that we need more of that skill mix, or that we have people moving. And when I'm looking across our whole system, and our system colleagues on the call will know this, we have got a national shortage of therapy, particularly occupational therapists, and then that ripples down from the southwest nationally down to our region and then down to us locally. But I started off my presentation by saying that one of the real positives was that joined approach, that sharing of expertise, that sharing and building on resources across, moving people around organisations to support one that's more in need of others. And I think that's a real positive that's come through us having to work in such different ways at such speed during and at the beginning of the pandemic. So we're constantly looking at how we do recruitment. We've been working with our HR colleagues around marketing, how we market, how we're marketing ourselves, and we're doing that within our wider system as well. What we are also doing is we have apprenticeships, that we have got a number of occupational therapy apprenticeships. We currently have got 3 people who have started the apprenticeship for occupational therapy, and others lined up for this year and next year and so on. We've been doing this for a longer time with social work, but it just takes a little while for them to come out fully qualified. But once we get into that ongoing, people joining every year, we will be growing our own occupational therapist and social work through the apprenticeship route. But this is a much wider challenge, really, not just within our system or just within adult social care. But I hope that answers your point, Councillor.
Yes, thank you. Thanks very much.
Councillor Matthews? Oh, sorry, Elizabeth, did you want to add to that?
Just in support of what Betty's just said, I just happen to be an occupational therapist by professional background, and what I would also add is when we're looking at the strategic view of an intermediate care service, a reablement service, all these services that help to keep people at home and help them to regain independence, we've got to look at not just the high level professional staff, but all the staff being trained in the same techniques. And quite often, as our senior occupational therapists are involved in teaching other people how to use techniques, or when I've gone to the market in other authorities for a new domiciliary care approach, it's often been with reablement, intermediate care techniques at the core. So I think there's lots we can do to expand this whole conversation about how we're using the workforce around professionals, particularly occupational therapists, physios and the like.
Thank you. I think there's quite a lot of different employers, not just sort of the NHS and social care, out after the same sort of people, really, aren't they? Councillor Matthews.
Thank you, Chair. Yeah, thanks for the presentation. It's just one particular point I'd just like clarified really a little bit more information about. It's in terms of supporting the care market and particular reference to the workforce recruitment and retention funds. I know you mentioned it to Councillor Wilson earlier about, I think you used it for the bonuses and stuff, but I was just kind of a little bit curious as how long the funding goes on for, but also how do people go about sort of applying for it? So how it kind of work at the moment? And kind of when it does run out, is there any, do we envisage that there'll be something else to replace it? Because clearly this a kind of ongoing issue. It's not going to disappear overnight. So those are my points really. Thank you.
Thank you. Who wanted to take that one?
Do you want me to take that one, Chair? So we are talking about a significant amount of money. The good news, it's 1.183 million at the moment. The next tranche is 2.184 million. The infection control grant is 3 million. We're talking about huge amounts of money. We're talking about we have to use it by the end of March for some of it. And you're right to ask the question, what do we do when these grants run out? But the really positive thing is being able to hand these grant monies over to our providers for them to support their own workforce. And some of the monies can be carried over for next year. And we're working really closely with providers to make sure that they can do that. So what I would say, it's a significant amount of money. It's going to make quite a lot of difference. We have got to work at pace. Of course we have. We'd hope there'd be more money online, but there's no guarantees there will be. So it's about using it wisely.
Okay, Councillor Johnson.
Thank you, Chair. My question really was to Councillor Butler about your neighbours. Did they think to use 111 before they called an ambulance? Oh, and then my question was to Sally, really, how widely used is 111 and does it take the pressure off? You know, how's it working? Is she still there?
I'm still here.
Thank you.
Thank you.
Yeah, shall I respond to that? We've got a significant use of 111. I think I've got my figures right that the use of 111 is 25% up this year than it was at the same time last year. We're fourth in the country for our performance in responding to calls through 111, which is a remarkable improvement because we had a real issue with the timeliness of response for 111. The other important element that's been only introduced very recently, which links to the bit to primary care, is that we've been doing a rollout, a very rapid rollout of direct booking from 111 into general practice, which is working really well. And not only the patients finding that a benefit, general practice is finding it a benefit because we were finding that people were bouncing around the system and coming in contact with different parts of the system more than once. So yes is the answer. 111 is used a lot. We still need to continue to promote it. People's experience of using it is so important because if they have a bad experience, they won't use it again. And the link with how they then go on to access the appropriate service for patients based on their needs is really important. So the element about that link into primary care, but they would signpost people to other places as well, is working well in Dorset. Always room for improvement, but working well.
Thank you.
Thank you. I had to call 111 the other Saturday, and I did have to wait quite a while, I have to admit, but they were very helpful and did alert A&E at Bournemouth that I would be coming in with the patient, and it all went very smoothly. So I was a little bit worried because it was Saturday afternoon and I just had visions of lots of rugby and football injuries in there. But luckily we didn't have to wait too long. So yes, I certainly recommend 111. They do give very good advice on there. Can I just ask, the hospital discharge funding, I presume that we're going to be asking government if that can continue after March. And linked to that, because we do have a lot of people in our hospitals who are actually medically fit to be discharged but just need the care package to be put in place, and I believe we've been placing them in care homes. Who actually pays for that care home placement? Is that self-funded? Is it BCP, or do the NHS pay those costs?
The chair, I could probably make a start that.
Betty.
So so the hospital discharge fund, and it, as I've said, that is up until the 31st of March. We haven't had any notification that we will have a continuation of that, but you know, we still have time for notices or notification of different types of funding up until and then after the 31st of March. So let's see what happens with that. With regard to people going into placements, interim placements, who are waiting for packages of care, the hospital discharge funding applies to people that have an enhanced need, so a different need to when they were admitted, or a completely new need to what they had when they were admitted. So they can qualify for the funding on those two criteria, really, up to a 4-week period. During that 4-week period, our teams that I referred to, who have helped over 3,500 people in that 6-month period that I captured, our teams will have assessed people during that 4-week period. So if I went into an interim placement today and I was funded under the hospital funding up to 4 weeks, I would and if I needed an assessment, I would have an assessment of my needs, and during that assessment, that would take into account what's my longer term plan. Do I need a package of care? If I did, they would look to support me to commission that, or they would commission that for me via brokerage teams. There would be financial assessment as part of your Care Act assessment during that 4-week period. So the principles are that at the end of that 4-week period, people know what their longer term need is, that's being commissioned, or they've gone home during that 4-week period with their longer term need, and all the assessments haven't taken place during that 4-week period. It is critical that we assess people within that period of time. So that's why we have robust systems in place for when people are discharged, that they are discussed, picked up and assessed really, really promptly, and that those outcomes are known, so that the funding streams and the allocation of care is very clearly known, you know, at the very, very earliest opportunity.
Thank you, Bessie. Can I also ask, it's not totally part of this paper, but where I know that you are asking where we've got people, as I say, in hospital that are medically fit to be discharged but need extra care, asking family members whether they can take them in and to look after them. And it's really looking at carers allowance, which, to be honest, is abysmal. I mean, this is not nothing that you can do anything about, but I'm just wondering as a committee whether it would be expedient of us to actually write to our MPs about a review of a carer's allowance, which at the moment is £67.60 a week. Now that could be for someone just nipping in and making someone's dinner, or it could be someone that's actually really looking after sort of someone almost 24 hours a day. And that only went up 35 pence a week in 2020. So a lot of people would not be able to afford to give up their jobs to take in a family member to look after them if they're only being paid that amount of money. So I don't know how this committee feels about the carers allowance. As I say, it's not strictly on this paper because it's probably part of our carers strategy. But I just think it's a terrible, I think, you know, it's a disgrace really what we pay them. Councillor Wilson.
I'd like to agree with you on that. And I think I would second and support strongly writing to the MPs as a committee. I'd be happy to second that.
Thank you. Anybody else? Councillor Robson.
Yeah, thanks. I was going to say something very similar, and I think that also connected to, as a recommendation on this, because one thing that's still not entirely clear on is, yes, we're throwing more money short-term at bonuses towards carers, but what's the I'm not still 100% convinced what the long-term strategy is for actually keeping that workforce high, keeping the workforce, you know, 2 years down the line. There's a fix here for 6 months. I get that, and I can see the work that's been done on that. But there's nothing in here that tells me beyond that where we're going. I'd like to see that as another bit of work if that's what we're recommending.
Sally, I believe you wanted to come in there.
Thank you. Yes, I just didn't want to miss the opportunity linked to your reference to the number of people that are in our hospitals that are ready to be discharged. We're now calling people that don't meet the criteria to reside. None of these framings are particularly pleasant, I don't think. But I'm glad you've made the link in there, and also the focus and the importance that you're placing in terms of how we can improve and grow the care market, because at the moment we've got just under 300 people across our 3 hospitals in Dorset, Bournemouth, Christchurch and Poole that are in hospital that don't meet the criteria to reside. That means that they should be going home, most of them, or to their place of residence. You can imagine the significant impact that's having on the hospital trust, but also on the individuals that are in hospital, because they decompensate and they really deteriorate in terms of their independence when they're in hospital. And so their experience and their outcomes is very much reduced. So I think it's very important that we are taking this seriously. It isn't an acceptable position to be in, but we are working under significant constraints in terms of all the issues that everybody has described today around the workforce challenges. We've got a lot of scrutiny on us in the patch from our regional and national teams. including the Secretary of State, because we've got so many people that aren't meeting the criteria to reside in hospital. And there's been a task set to all areas to reduce that number by 30% by the end of January and 50% thereafter. We are way off the ability to do that, and we haven't got robust plans to be able to get to that point either. So I do think it is really important that we are taking this serious, because not only is it not good use of resources, it's really detrimental to those people that are in hospital and don't need to be.
Phil Hornsby, I believe you wanted to come in on this.
Yes, thanks, Chair. It was in response to the question about how do we recruit and retain a workforce for the future, not just short-term fixes. So the government recently announced work that the councils, together with colleagues across health and social care, need to do around a sustainability plan. And this all linked to the Care Act and the recently announced Health and Care Bill. So this is where the government's saying, how does it address the long-term funding of social care and the long-term needs within social care? So some of this is a link to a small amount of money, well, not a small amount, 1.2 million to develop a sustainable market. And Elizabeth and colleagues will be working on plans with CCG colleagues and the providers themselves around what's our long-term vision to support the market in such a way, and it won't just be about money, it'll be about training and development for staff and career pathways to make sure we have the right staff that are valued and recognised as professionals and not just care workers, which sometimes they reference themselves as, to put us in the best place possible. It isn't going to be easy because there's a lot of competition in our area for workforce. This has already been referenced. So we're going to have to think differently about what we do and how we do it. And it's also about how do we give them the technology and the tools themselves as staff to work with that allows them to do more or work differently in a more modern way that supports the greatest number of people that we possibly can. So a lot of the things that we've talked about already tonight, and just in addition to the bit that Sally's just said, how as a system are we going to respond to meet all the care needs and have the right workforce, rather than how is a local authority going to respond? How is this GP going to respond? How is the acute hospital going to respond? So as a system, we need to think differently, and that's our challenge. And we need to come up with a plan in reasonably short order of time to make sure that we can look forward for 2, 3, 5 years rather than 2, 3, 5 months. Thank you, Chair.
Thank you, Phil. I was quite pleased that we have apprentices, because presumably we do pay an apprentice levy, so we might as well sort of use that as we have to pay into it. And that may be something that we need to communicate to the schools for those children that don't want to stay at school till they're 18, that they can leave earlier and become an apprentice. It might be something our comms team can sort of work on to send around our schools. I just wanted to clear up any confusion that anybody might have. Councillor Rampton pointed out to me, I was referring to informal carers, not people that work in care homes or work for agencies. I was talking more about people that look after a parent or a partner or something. They're not an official capacity, sort of. Councillor Robson, did you have a recommendation that you wanted to put to send into the cabinet?
Well, that's sort of it was touched on those last answers. Actually, I think the work is going on to find that longer term solution, but I think it's probably one for cabinet just to monitor and update us on. It's been said, but let's hear back on it, I think.
Okay, thank you. So I just wondered how you felt about the recommendation for a review of informal carers allowance, especially in relation to the level of the care required, and that we ask Cabinet to write to our MPs, because we've got quite a few MPs in this area they could write to. So I believe Councillor Wilson's going to second that. Is everybody in agreement? Yep. Okay, thank you. Has anybody got any more questions? Councillor Butler.
Yeah. I was just going to ask, I know you mentioned apprenticeships, but do we offer any work experience to students? Because that might actually trigger an interest in something that they might be able to do as a career.
I could take that, Chair.
Yes, thank you, Betty.
Yes, we do. We offer quite a lot of people coming to have a taster session, if you like. I mean, we have to be careful about confidentiality and the nature of the client groups that we're working with. But if we're safe to do that, then we often have people come for a week or 2 weeks or just to buddy up. And that's in addition to having students. And just on the whole student and apprenticeship thing, what we're saying is that when we have students, it's a really good way to recruit because you can see those really shine, those ones that are shining stars that you think are going to have really good potential. And then you're encouraging them to come back and work within the workforce once they've qualified. So yes to that, Chancellor, and we have got a really good training team who are fully committed, really driven to get, to support people to come into our workforce, but also to really grow them and develop them internally so that then they can go on to do the same to others that come in. It's about teaching each other and having that ongoing model, but also about growing our leaders of the future as well within all of that. So yes, very supportive of that, and we do that.
Thanks very much.
Thank you. Councillor Evans.
Thank you, Chair. First of all, I'd just like to say a huge thank you to our BCP officers and colleagues across the health and social care sector. It's been an unbelievable 2 years, and I think you guys have all been absolutely amazing. You've stayed positive when I think a lot of people would have just turned and run. And kept everything going. It could have collapsed and it hasn't, and I think we are actually going to get through this. So just a huge thank you from all of us to all of you. In terms of recommendations to Cabinet, I'd very much like to champion the Proud to Care awards and all the things that we can possibly do to encourage the recruitment and retention of our carers, and ask for Cabinet support for that, whether it's through funding or through other means. Thank you.
Did you want that as an official recommendation to go to Cabinet?
Yes, please.
Did you want to put the sort of wording down for Joe? Is anyone second?
I'll second that.
Thank you, Councillor Matthews. Does the committee want to wait for the official wording, or they get the gist of it? Well, yeah, you're all happy with that? Yeah, okay, good. Wasn't that? I know it wasn't a difficult one. Anybody else on this agenda? No. Thank you very much, Betty, Elizabeth, for that. So if we move on to agenda item 9. Which is the Adult Social Care Emergency Duty Service. So, Betty, are you taking the lead on this one as well? Right. Got a busy night, Betty. Thank you.
Thank you, Chair. I will bring my colleague in, Nikki Hiles, who is our operational manager. So when and if I need to bring Nikki in, she's kindly joined us. So you have the paper in your pack. I think the paper starts at page 25. I'm just going to do a bit of a synopsis of the paper for you, but not in too much detail. So our current emergency duty service, this particular model that we have for adults, came into being in 2018 when it was just for Bournemouth and Poole, and then April 2019 it became for all of our BCP adult social care residents or people that would need that service. So as it currently stands, our emergency duty service, which is often referred to as EDS, consists of 5 contact officers, and these officers are really skilled in screening and risk assessing calls that come into this particular area, because usually the calls received are when people are in times of crisis. And these particular contact officers are also able to act as appropriate adults when needed. So when people are, called to the police station, they need to go for interviews, and we may be worried about their vulnerability. They're able to go and accompany them if there's a need for an appropriate adult, and they are the best people, or there's no family or anyone who connects with that individual. We have a number of mental health act practitioners as well, and our mental health act practitioners are practitioners that are approved by the local authority, social services, to carry out certain duties under the Mental Health Act. So they undertake particular training that enables them to do this and gives them the right to act in this way and to be able to be appointed to this type of role. They can be social workers, they can be occupational therapists, they can be nurses. In the main, they are dominated by social work practitioners undertaking this role. Our emergency duty service is that it operates outside of normal working office hours, if you like, although they're changing as well. But they operate from 5 o'clock in the afternoon through till around 9 a.m. the next morning. They are 24 hours at weekends, Saturday, Sundays, Christmas Day, all bank holidays. They are a single point of contact for adults in crisis, or for someone to contact if they are concerned about an adult or somebody's immediate welfare. It's an excellent service. It's a service that is, we absolutely need this service, and we need it to be robust and good and able to do the roles that we've put it in place to do. The responses that they tend to deal with, or the type of work they tend to deal with, is adults in crisis who require a statutory assessment. So particularly under the Mental Health Act. I spent some time in this team when I managed it more hands-on, and would go out at night with the practitioner, and it really truly is an amazing service. If you're okay driving around late at night in the middle of the night, does take a certain type of person to be able to do that. But I have seen the best of what they can do, and the individuals that they really, really are able to help and support. They will also support adults experiencing harm from abuse or neglect, so vulnerable adults who there's been safeguarding concerns identified. Also people who are in desperate need of support at that time, practical support, a package of care, might need to go into a residential placement. When I was doing a shift, I was, putting people into temporary because something had happened in their building, or something had happened, but they just weren't safe to be there the rest of the night. They also will do urgent signposting that's needed. Because we have to remember this is an emergency duty service. It's not a normal standard service. It is for those people that are really facing some kind of a unique crisis. Just to give you some, and it is in the report, just to give you some indication, this particular service, receives really high volume amounts of calls. You'll see that between April and November 21, they had 2,767 calls. And what we've seen is that more and more and more of the calls are absolutely necessary. The level of inappropriate calls have really decreased, which is showing that the public are understanding or the professionals that are referring in. We work very closely in partnership with the colleagues in the police service, within our acute hospitals, within our mental health hospitals, all of those kind of areas. You know, we work in such a joined up way. The highest proportion of work that comes into the team or that is undertaken by the team, which won't come as a surprise, is those particular cases that require mental health act assessment. That's the highest number. We've also seen where maybe we do need to do appropriate adult work. That's come in. That would be our next around with packages of care, those in real need of packages of care. Since the pandemic, our emergency duty service have not stopped seeing people face to face. It is not the kind of service that you can make a judgment over the phone, because you will be taking away people's liberty and their right to choice and self-determination in some incidences, if we need to, for their own protection and safety. So that service has not seen any difference really during the pandemic. They have continued as they always have done. The financial cost to the service is, the budget for it is 775, just over £775,000 a year. Almost all of that is on staffing, as it should be for that type of provision. And I guess just to finish off, our legal duties and requirements fall within the Care Act and the Mental Health Act. So that's just a quick summary for you, Chair and Committee, of the report. Thank you.
Thank you very much, Betty. Can I just ask you, because I'm not always very good with some of these, on page 27 on your graph, it says BCP, I get that, Bournemouth, Christchurch and Poole, but what is CYPSC? I had a bit of a job, I tried to work it out, but I couldn't. So I just wonder if you could tell me, please.
Sorry, apologies for that, Chair. That is our children and young people services. Apologies for that abbreviation.
Yeah. Anybody got any questions? Councillor Butler?
Yeah. Yes, on your pie chart on page 28, you've got a percentage in blue, and there are a few blues, and I can't see a key for that blue. It's 45%, but it doesn't say what it's for, unless I've missed it.
Sorry, Chair, that is for our Mental Health Act assessments.
Right, so that's not the 30%, no?
Nikki, is that's correct, isn't it? The highest percentage is Mental Health Act.
Yes, yeah, it is.
I think it's the darker blue, Councillor.
Yeah.
45%. There's three blues on there.
Four.
Yeah, we will use different colours, sorry.
Right, okay. So what's the 30%, the one on the right? That's...
Nikki, is that the appropriate adult?
I'll be absolutely honest with you, Betty. I haven't got it in front of me because I can't see it.
Chair, I'm sure that that's the appropriate adult.
It's AA, yeah. I thought it was alcoholics.
Appropriate adult. AA is appropriate.
Appropriate adult.
Yeah.
That would be our second highest, and then care packages after that. That was the three most. So that is definitely appropriate adult.
Right, and am I correct in thinking that the residential is 1%? It's the smallest one.
Correct.
Yeah.
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 Okay, thank you. Yeah.
Councillor Wilson?
Yeah, thank you. Firstly, just to really praise the work in the report and to praise everything you do. It's a really important service, and I think you're right when you say it takes a certain type of person to do this. And yeah, it's just amazing, really. I just had one small question. It's more out of curiosity than anything. I think you mentioned it before. Nearly all of the budget goes on salaries, £760,000. I think that leaves 15,000 left. I just wanted to know what that kind of would normally go on, what that would be used for.
Nikki, do you want me to take that, or do you want to take it?
Do you want to take that?
Is that okay, Chair, if I take this?
Yes, that's fine. I thought it might be phone bills, but
Yeah, so it is a very small amount, and that would be on, you know, we keep a small provision of stuff in the office as well, just in case we need it. So that might be if we're giving somebody an emergency fund as well, similar to what our crisis loans would be. We've had to do that the odd time there, but it's also around some elements of training. No, it doesn't go on biscuits. That would be, they would be nice biscuits. So it is small groups of you know, training, just having a provision, a small pot within that team because of the nature of what they do. But if you want me to, Councillor, I can give you a very defined list of what that's actually used for. I can get that to you tomorrow if that would help.
Would you like me to just give you I can give you a few little things that we kind of tap into, because we don't have any resources. So we tend to have to pay perhaps train tickets, or we obviously do food parcels and things for people who are in need. It's kind of the little things. We also support children's services as well, so sometimes we have to help each other out. But yeah, it's a little fund that we have to tap into every now and again, and that's possibly a surplus at the end of the year.
Yeah, and you know, just to add to that, Chair, if I may, when I was there, I can remember we funded a taxi. Out of that, you know, we agreed to pay a taxi to take an older vulnerable lady to a place of safety, and we used some of that. So it really is at the team's judgment, but it is all done and audited and all that kind of stuff. You know, there's a process for it.
thank you. Okay, yep, okay with that. Yep, okay, thank you. Councillor Butler.
Yeah, on item 10, page 27, it talks about OT equipment, and I noticed in the Echo recently there was a plea for lots of people to return their equipment for reuse. Now I can see that's quite an expense for the service. Is there any way we can encourage people to return things, maybe publicise it more?
I could answer that, Chair.
Yes, that's fine. I mean, I did see something outside A&E actually at Bournemouth saying return your equipment here, but I do know that the service do collect. But yes, thank you, Betty.
We do. We do have with our provider of equipment. NRS is our provider of equipment, and we do have huge amounts of returns. You know, for across all of our service areas who issue equipment, be it our emergency duty service or our long-term or our learning disability or mental health services. We have huge returns, and then they obviously will go out for cleaning and to make them safe again, to be reissued back out to others who are able to use them. Huge amounts of returns, Councillor, and we need those huge amounts of returns to keep down our expenditure, but also to not be wasteful with equipment that can be reused. I mean, of course, we adhere to all the hygiene requirements and specifications about reissuing, and you know, no cross infection and all of those type of things. But yes, a huge area of returns for us.
Thank you. Got a further question?
Can I just ask who people would contact if they want to return an item?
So for members of the public, you know, if we've issued them with equipment, they can come through our contact centre and just provide, we will direct them how to do that, or we will get someone to contact them on how to do that. What I would say, Councillor, is a lot of people who we do issue equipment with have other issues or other long-term conditions and needs, and that a lot of them will already be open to us, or we'll have a health or social care professional already going into them. So, you know, they, in the main, they would have a conversation with them, and then equipment can be returned that way or different equipment reissued. So they can either come through our contact centre, use the practitioners that are already involved with them. And yeah, that's usually our routes in.
Thank you.
Councillor Robson.
Yeah, actually, yeah, just a quick one. So I'm assuming this is what it's going on, but those 5 officers, are they on permanent duty throughout that night, or are these 3 on, 2 off, and weekend permanently on, and they're all 5? Yeah.
Nikki could answer that.
Yeah, let me answer that one. We have 3 contact officers on shift over an evening. So we have a 5 till 11:30 shift, and then we have a swap over. We usually have 2 contact officers on during that time, and then overnight we usually have 1 officer on. So there's always somebody to answer the phone, always. They have access to an approved mental health professional who's a social worker. So we always have an approved mental health professional working alongside them. So if they ever have any complex cases or there's something that they need to pass on to a more senior person, they can do that. And then there's also a manager who's on duty as well, which tonight's me.
Lovely, thanks.
So are you saying that after 11 or so they go out alone, do they, to visit these people, or are they accompanied?
The contact officers remain at home. They're answering the phone and taking the calls, so they don't tend to leave home or the office space when we get back there. Our social workers, AMPs, they go out alone. So yes, we visit alone, but we usually go in, we end up meeting a team. So although you might be travelling somewhere alone, you're then going to be usually meeting a couple of doctors and obviously your patient, perhaps transport, depending on what the work is that you're actually going to be doing. But you will travel alone, but you will meet up with somebody. And obviously the contact officers, not obviously, but our contact officers are aware of who's doing what, when, where, how, and what time frames we're expecting. So you've always got somebody who's in contact with you. So they're always checking on you. They're making sure that you're getting back. They know where you are and you're safe.
Okay, I was glad to know that, yes.
Yeah.
Can I just ask about on page 29, note number 13, about this mobile phone app? Who is that designed for? Is that designed for your staff, or is it, I presume it's for your staff and the doctors, is it? And also, can I just ask on that, where you're having problems getting, well, you want to encourage doctors to have these overnight assessments. Do they get paid extra for this, or is this sort of part of their role generally? I mean, is there a financial incentive for them to do works after 2 a.m?
Do you want me to answer that, Betty?
Yeah, you start.
Let me start with the app. The app itself is a health app. Health organised it, and we support it. And it's run not just out of hours; it's run during the day as well. Mm. So if you have a mental health act assessment request, that's how you organise your team. So the AMP will put a request onto Lantern, which is the app, and they will request doctors. For us in out of hours service, we have a doctor on call all the time, supposedly. And when the first person we would call for an assessment is that doctor on duty, and we'll start liaising with them to organise a time to do the assessment. But then we have to put out a request on this app for a second doctor, because every mental health act assessment, you should have 2 doctors with you, as well as the AMP social worker. And we have real difficulties getting doctors after 12 o'clock. Sometimes it's after 10 o'clock in the evening. And I think that's more around the fact that there aren't so many Section 12 doctors available. Section 12 doctors, the COVID pandemic has hit, as we've been discussing all evening, the NHS, health and social care. It's hit across the board. We're asking doctors to work during the day and then do evening work. So, you know, it does put a high toll on people. So, yes, we do struggle to get doctors, especially after midnight.
Thank you. Betty, did you want to come on that?
Yeah, thank you, Chair. Just to add, I think that is a challenge that is faced much wider than just in our system, and we are working very closely with our CCG colleagues around how we can add to our kind of complement of Section 12 doctors as well. So that, because the more we have, you know, on our kind of bank on our rotas, then the more we're able to access them promptly. What I would say is, when it works smoothly, it is amazing to see, you know, the Section 12 doctors, our approved mental health practitioners, all collectively, promptly working for the best interest of that individual who 9 out of 10 times at that particular time is experiencing real distress. Thank you.
Yeah, thank you for your answer. If Louise Bates still there, yes, thank you, Louise, and I hear you have to go on to something else, so thank you. I also wanted to, I believe it's also difficult to get approved mental health practitioners. Is this just another general one? I just wondered what was the difficulty in recruiting this? Is just not enough being trained to do it, or they're being trained, say, locally at Bournemouth University and then sort of either moving home or moving to different parts of the country? Do we work with the BU in their sort of nurse? I presume we did, yes, to try and retain them down here.
Chair, if I take that, and then Nikki might want to add, I think mental health practitioners, you know, they do additional training. It is quite intense, the training. I think also the type of work that they're involved in can be quite distressing. So it is about how we kind of try to balance that out for them as well. And it is nationwide. We have never, ever, as far as I can recall, had too many or even the right amount of amps at any one time. It's just that area of practice. We do really well to maintain the level of amps that we have, and we do really well to maintain our daytime rota as well, because this is just our emergency duty service at night. We also have people that are in need of mental health assessments throughout the day. So we do really well to maintain our rota of our quota of people that we need to have on duty. We always have a first, a second and a backup. And we do really well to be able to do that. You know, we're probably not in those areas that really struggle. I'm not saying it's easy, but we've, you know, again, we've got some excellent practitioners and managers for that, but it is an area that's very challenging, and we are looking at how we continuously kind of can just keep adding to that complement. And we have, I think we have 4 people going on to do their approved mental health practitioner training. And we constantly do that with our general flow of social workers and our general flow of OTs. We're really encouraging our OTs to also train us on. So we will do that with our professional staff, and then they can go on a rota. But like I said at the beginning, the emergency duty service takes a particular type of person who wants to work nighttime and who is an approved mental health practitioner as well.
Yes, thank you for that. And obviously 2 years of a pandemic hasn't helped increasing the numbers that they have to deal with as well. Members, anybody? Good. Councillor Evans.
Thank you, Chair. Just a very quick question for clarification. On page 28, it talks about referral types. and mentions the general acute hospitals and community mental health hospitals and police custody suites. It doesn't mention any referrals in from general practitioners or primary care.
Do you want me to take that, Betty? We tend to, in the emergency duty service, because it's outside of normal working hours, we don't tend to get them so much. I'm afraid that normally goes through day service. And we have our own AMP hub in BCP Council. So there is a day service AMP hub, and they have at least 5 AMPs on duty every day. And they do screening constantly, and they've had a huge increase in their numbers coming through. The other thing that normally happens is that we have a handover. So every day we talk to our day service, and EDS have a discussion with them. We do a handover. So we sometimes will take late assessments that have come in through the day service. They'll hand over to us because they either haven't had staff to do it, or it's come in too late and it wouldn't be appropriate for them to do it, and we'll get it. We occasionally get those. They might have come through from a GP practice, but I would suggest normally ours come through the hospital's custody, police picking up on a 136 and taking through to St Anne's Hospital. So yeah, that's our main route.
Sorry, I hate to disagree. I do actually work as an out-of-hours GP, and we do quite a lot of referrals. And as you say, the in-hour service ends at 5 o'clock and GP practices finish at 6:30. Yep. So I'd be interested to see those figures, if we could, please.
Yeah, I can find those for you, not a problem.
Thank you.
Thank you. Anybody else? No? Yeah, I'd like you to, I think everybody here on the committee, thank the staff for the job that they do. Yeah, especially travelling alone at sort of 3 a.m. in the morning in horrible cold winter nights can't be too pleasant, and not knowing quite what you're going to get to when you arrive, you know. So yes, thank you very much, and thank you very much for the comprehensive report there. So moving on then to agenda item 10, portfolio holders update. So if I can call on Councillor Karen Rampton first, please.
Hi, thank you, Chair, for letting me go first. That's great. I thought committee might be interested in a bit of an update on our care technology. So you'll be aware that I've kind of mentioned this in the past, and that we had some money in the budget previously to do a piece of work. And so in December, we commissioned Hampshire County Council and PA Consulting to do a diagnostic review. So not a business case, but a review. We went to them because they're sort of leaders in the development of care technology. So a bit of background, we at BCP, we currently spend more than the England average on care for older people. And that's for a lower percentage of the population. And you'll know that from the adult social care strategy. We kind of recognise that our care technology is a bit limited, and there's a huge potential to enhance our services and of course the quality of life for our residents across adult social care and housing in particular. But other service units could probably benefit from care technology or technology as well. So we're behind the curve and we need to catch up. We've got fulfilled lives in our corporate strategy, and that references the use of assistive technology. We want the offer to be available from the first point of contact with people, and we need to embed that innovation that technology can provide for current and, of course, future residents, those coming through. So we've got that vision of a service which can be absolutely transformational. At the moment, our offer that we make to residents is quite traditional. So it's sort of false alarms, pendant alarms, and those are within our care line and our lifeline services. And you'll be aware that there are still, excuse me, Chair, there are still the 2 services, but they're being brought together. And in fact, they've moved to their new premises at Creekmore. So once the IT systems are up and running, and that should be Easter time, I believe, we can look to expand that offer. But as I say, we need it to be transformational, not just a mere expansion of the existing service. So if we transform and embed our care technology and using that strengths-based approach that we keep talking about, not only will people maintain their independence for longer, but the quality of their lives should be improved. And also, of course, there'll be a saving to BCP. I'm not going to quantify what that saving could be from the diagnostic review, but there will be a business case, and I'll talk about that in a minute. So we need to reach more people, we need to grow the service, and we need to reach younger people, and we need to reach certain cohorts of people, such as those with a learning disability, and things like GPS can help with people who have more complex needs. I just thought you might be interested in a little case study. And I'm going to take this fictional person called George, and George is 76, and he lives alone. He has family, but they live at some distance away. And George has always been very independent and active in his local community, but his health's gone downhill. Oh, sorry, let me just shut the Chair, apologies for my dog. So where did I get to? So George, his health's declined and he's at an increased risk of falls. So his confidence is affected and he doesn't go out very much. His family are obviously quite anxious. They can't get to see him as often as they would like. And they're in touch with the council about us providing a care package for George. So today, with the offer that we have today, George would probably get a pendant alarm or a fall detector. And he'd probably need a care package for help with his shopping, etc. But he'd still be a bit isolated. And it would still be, it would be quite costly for the council or for George if he was paying for himself. If we took a slightly different model, a slightly more enhanced model, George could have a GPS-enabled device with built-in falls detection, and his family would be alerted if he was outside of his home, or we could create a safe zone, and if he was outside of that, they would be alerted. He could get help from the monitoring centre, and if he needed that when he was out and about. And this would increase his confidence, and it would help him to access his community. And also he'd be delaying any need for a care package with those associated costs. If we have the transformed care technology service, and that's all sort of embedded in the strengths-based approach, George could have a series of digitally connected aids. So there's something called smart socks, which I hadn't actually heard much about, but I looked it up, and apparently it's very effective for people who are diabetic and perhaps have a foot ulcer, and it's a little device that people wear in their socks, and it collates data on health. So it could collect your heart rate, test your oxygen saturation and other biometric data. And as I say, it's been quite effective for diabetics and other people who have foot ulcers. So he could have a range of aids which all join up. They would predict the likelihood of a fall, perhaps. They could then intervene with some preventative suggestions for George. He could be connected to his family and friends. Now that could be through something that most of us have in our homes, like an Alexa. So he could use the range of devices that could all link up, and he could be supported more safely in his community. And of course, that would lead to a delay in any care package being needed, and that would save costs for the council, and it would save costs for George as well. So I think it's really, really exciting potential ahead, and I feel that we should go big on this, and we should go soon on this, because it's out there, the technology is out there, it's growing daily. So the next steps are to work up a business case, and then we can select from that an operating model, and then we can take it through the democratic process, which of course would include your committee chair. And I'm happy to take questions. I may have to call on officers if it's very technical, but I hope that was of interest to committee. Thank you.
Thank you, Councillor Rampton. Anybody got any questions? I presume that thing that you were saying you put in the sock, I mean, I haven't got one, but I'm sure some of the committee members here are wearing those watches that do your heartbeat and everything like that. So presumably we'll be looking at those sort of things because they could be linked into the GP surgery or their family or whatever, so they can keep an eye on that as well.
Yeah, yes, Chair, and I think something like that is actually available now, but this is taking it a little step forward.
Thank you. Any questions? Thank you, Councillor.
Yeah, thanks, Chair. Yeah, I love all that technology. I absolutely agree. It can all be beautifully linked up. Just one thing to consider with that it's all well and good until, like we had the other day, we had an outage in our house that Scottish and South West had to come and fix, and all that technology went down. Absolutely all of it went down. No internet connection, couldn't even, the first thing I went online to get hold of the energy provider, but of course that was down. Back to good old-fashioned telephone. So as long as that's considered into the plan and somebody is monitoring all that, and there is a response to that, because sometimes the technology, it is great, and you're expecting to hear from it, every 3 hours, and when you don't hear from it, that obviously gets another response going, and sometimes that response actually isn't needed. It's just the technology that's gone down. So I'm all for it, and I think, but it's not always the sort of golden egg that people think it is my concern.
I think that was an observation, was it? More than a question.
Yeah, it was an observation. It was a question in the form of, as long as that's being considered, and we're not just taking all this tech at face value that it can do all these wonderful things like the smart socks and things, which it can. We know it can. Technology is out there that can do all this thing. But as long as it's being the whole package is being considered, it was my sort of, doesn't need to be answered now necessarily, but it was just a sort of observation, I suppose. Yeah.
I presume they could have something linked in that if the person will still have a landline or a mobile phone that they could ring. I know Careline, if they think there's a problem, they can speak to the person, so unless your phone line goes down, which I know obviously can happen.
Yeah, because I've had Careline before, and Careline is great as long as the person on the other end can shout and get hold of the Careline. But if they're falling down in a room where they're face down and can't shout to the monitor, or don't have the presence of mind to shout to the monitor, then that actually doesn't work. And it was great technology, but it doesn't necessarily provide the answer.
Phil Hornsby.
I'm sorry, Chair, I was just going to come in. I was just going to say, obviously it would be part of a suite of services, wouldn't it? And there are already, there are already systems in place for people who are vulnerable and who use our Lifeline and our Careline services. So the new technology is something that would be part of a whole offer to people. And it's a fair point. I mean, it's like us now, isn't it? We're all online. If we get a power cut or the internet goes down, then we lose it. It's obviously more worrying if it's somebody who's vulnerable and whose health might be affected.
Thank you. Phil, did you want to come in here?
I just want to thank Councillor Robson, because I think that's a good observation, a good point for us to consider when we put together the strategy and the business case for the next phase of transformed technology. So just to assure committee, and we will be bringing this back at a point in the future when we've got a more developed plan, that we'll factor that in and talk and understand from Hampshire's experience how they've coped with such situations, because I think that we can learn from the best in the country, and that's why we're working closely with them. But thank you. I think it's a really helpful point to raise.
Thank you. Anybody else got any questions? Councillor Wilson.
Again, yeah, it's more of just an observation following on from Councillor Robson's observation there around kind of just maybe providing some training and some kind of understanding, because these are probably going to older, more vulnerable people who wouldn't necessarily know how to use different technology. Obviously, some of the technology is very simple, but if it gets more complex as new technologies come in, just appreciating that this being used appropriately and people know what's going to affect it and things like that.
Thank you. Councillor Butler.
Yeah, I've got two questions. Who's the data fed back to, or does the person have to feed it to somebody? And also, how do people who are hard of hearing or who've got sight loss cope with this technology?
Councillor Rampton, do you have the information there, or did you want one of the officers to come in?
Well, I saw Phil stick his hand up, so I think I'll let him take that one.
Phil, did you want to take that?
Thank you. So Councillor Butler, we haven't got to the design yet of what the new service is going to look like, what the transformed service will be. So all of these factors will need to be taken into account. Where's the information held? Where's it fed back to? Is it back to our monitoring centre, the people who provide Lifeline? Is it back to an individual carer? Is it to a health colleague, a GP, or an out-of-hours service? So all of those things will be addressed in the business case when we've got that further developed. We've just done the discovery phase, really, of understanding our current position and what the potential is to do something very radically different. We're not quite there yet in that case to bring back to members to consider, but we will take that point on board. Thank you. All those points on board.
Thank you. It's quite an exciting future, I think, for a lot of our people, yes. Anybody else got any questions for Councillor Rampton? Oh, Councillor Iyengar, thank you for waiting so patiently. Now's your time to shine.
Okay, probably risk I bungle the moment. No, thank you, Chair, and it's absolutely a very, very interesting conversation to tune into. So thank you for that. It's my pleasure to be waiting here patiently. I've just at the end of the meeting, I've just really got one item, please, to share with the committee, because I don't want to repeat what's just been said or what Sam Crow was mentioning earlier on about the COVID update. Just one thing to brief you on, please, and take any questions on, is the emergence of what's called the integrated care system. So many of you will be familiar, of course, NHS and administered through the CCG, the clinical commission groups throughout the UK, and also you'll probably know that nationally there's going to be a sort of shift of arrangements, if I can put it that way, and CCGs will transit to a new form which the government's calling integrated care systems, or ICS. So we will have one, and you forgive me, you may know this already. We will have what's called a Dorset integrated care system, which formally will go live at the start of April, so fairly soon. And there's a chief executive, Patricia Miller, an external who has been recruited to the role. There's a chair, forgive me, I forget the lady's name for the moment, the new chairperson, and of course in a sort of spat of new faces on the patch. Of course, we have Siobhan Harrington, who's replacing Debbie Fleming as the CEO of the University Hospitals Dorset as well. And as well as that, there's me, new portfolio holder, and there's a few other people as well. And I suppose, the skeptics may say, well, okay, we've just changed the name. Will anything change at all? And on the side, one can have that debate. But there is something here where certainly as BCP and BCP together with Dorset Council and as local authorities working with the other partners, we want to earnestly put work into sort of taking the higher ground and sort of seizing what the challenge is here, grabbing hold of the challenge here, which is a genuine multi-partner working. And I'm not saying at all for a moment there hasn't been, but to try and take it to the next level in terms of multi-partner working for sort of the greater good, the greater community well-being, health and well-being in Dorset. Formally, I'll only give you one boring bit of structure in all of this, and please, I'm aware you can't see papers. My apologies, this is just a verbal update to you. But the bit of structure that I'll give to you is there's what's going to be called an ICS board, an integrated care system board at the highest level, which of course the chief exec, the chair, will sit on, and that will be predominantly health professionals on that. But below that, and I think this is where a lot of the discussion will be happening, is what's called an integrated care service partnership, and that will be multi-partner. And of course, we earnestly hope, and we're lobbying for the local authorities to be prominent in the partnership, both ourselves and of course Dorset Council. And that's not to overplay our hand, but to make sure that everything that local authorities can offer and can lobby for and can move forward and actually implement is absolutely there in that partnership discussion. So who's in there? Of course, NHS Primary Care Network, of course, will be in there, local authorities, the emergency services, and then, of course, this is to be decided which of the specialist organisations will be there across the whole range of things: housing, welfare, education, care, and various other things, probably crime related as well. So that's to be decided. I mentioned the ethos of it is around a genuine multi-partner approach, and unsurprisingly, it's there to pursue this difficult but most worthy thing, which is, it's paraphrased as intervention before the front door, which is before the person ends up in hospital, what was the long chain of events that happened before the person arrived there, and how can appropriate interventions be made earlier on to, well, not quite prevent that happening, but engender a better outcome for all. So that's what discussions will be about. There's a lot of collaboration to happen, and a lot of sometimes quite difficult collaboration to happen to set off and start the way we mean to carry on. And at some point with Karen Rampton, myself, with Drew Mellor, and with others interested, we hope this will not only be brought back to this committee with more sort of specifics around it, but also it'll be the subject of a broader councillor engagement as well, so that we can take broad input on it. I'll finish there. I know that's been rather general, but I hope I've reassured people, at least initially, that we're on this one and we're getting BCP involved in these core discussions, and not least, in fact, just last week, in fact, we were consulting with colleagues over at Warwickshire County Council. They're a good year, 15 months ahead of us in this journey to pick up some of their tacit learnings as well. So we're absorbing like a sponge, and we're getting involved where we can. I'll finish there, Chair, if that's okay, and thank you, committee members.
Thank you for that. Well, the public who are viewing this won't see, but I believe Sally Sancroft sent a message across. Sally, are you still there? I think you said it was going to be launched in July.
Thank you. Yes. So nationally, they've moved it to July from April.
I do apologise. Actually, I said April. I didn't know July.
Yeah, don't worry.
Sorry about it, everybody.
Don't worry, and that's still subject to changes in the law. So we've got a little way to go, but everybody's working to that timeline. And it's a nightmare with acronyms, isn't it? And we have been sort of working as an integrated care system for a while, and the formal name will be of the new organisation, an ICB, Integrated Care Board. That's the name of the new organisation. And as you say, Councillor, Patricia Miller is the designate chief exec, and I just put in the chat that Jenny Douglas Todd is the designate chair. Thank you.
Thank you. Committee, any questions about this? I mean, I know it's been mentioned quite a few times on our forward plan. I think it's dropped off, but anyway, yes, it will be handy to have it put back on, I think, for later in the year after it's launched, sort of probably late in the year, sort of see how it fares if it does get launched actually in July. And anybody got any questions? Any questions at all for Councillor Iyengar? No, thank you very much. Thank you for that. I think move on to agenda item 11, which is our forward plan. Has any members got any questions on this? If I could just mention the structure plan update, I think it would be useful if the report is ready, whether we could have the birthing centre put on with that as well. I think it would slot in there quite well, because that's been delayed quite a few months now, hasn't it? And also it would be interesting if that report comes back with the sustainability, the buildings and climate change, climate emergency, and the type of I think I brought it up, O&S, the BREEAM that they will be looking for excellent or good in their infrastructure projects. But has anybody got any questions on any of the forward plan? Councillor Robson?
Yeah, we talked about it a while ago, just maybe bring our suicide prevention progress report and that homeless sleeping healthcare report, hearing some of that. We said early on this year, but
Yes, we'll need to ask officers how they're getting on with the report. Yes, because that would be a year in April. Yeah. I'm not sure whether the hub's been set up actually. That they were talking about it, weren't they? For the health services for the homeless. So it may need to be tied in whether that is actually up and running. I know they've got the building, I think, and the funding for it, but whether it's actually functioning at the moment, I don't know, and it might need to be tied in with when that opens. Councillor Wilson.
Yeah, I was just going to ask about dentistry provision. I think this is something that has been quite recurring, and I just wondered where we are with that. I think just looking at it, it says that it was requested. Well, it will be basically a year from when the next meeting is. So, yeah, I was just wondering, have we had any progress on that? Because it's still quite a important issue, I think, for people.
I think we did have some update from Health Watch because they'd done a project on it, but I don't think.
Yeah, I do recall like a brief kind of note from them saying they had done some that they had managed to find out of the 95 registered dentistries. I think there was like 93 that weren't seeing NHS patients. I think, but I don't. Beyond that, I don't think we've really gone into any depth about it or anything like that. And obviously, it's been on the forward plan quite a while. So, just if there's any kind of update, if that could be.
Thank you. Anybody else? No? Nope. Okay. Well, thank you very much, everybody, for attending in person and remotely, and close the meeting at 2016. Thank you.